Dr. Leocadio Rodriguez Mañas, Director of the Global Aging Research Network of the International Association for Gerontology and Geriatrics. It is my great pleasure to introduce to all of you this set of webinars focused on the benefits and prescription of physical exercise in older people, jointly to other sponsors, including the Public University of Navarra, the Spanish CIBER on Frailty and Healthy Aging, and the Regional Health Service of Madrid. This course, coordinated and led by Professor Miquel Izquierdo from the Public University of Navarra, will address the general issue of physical exercise in several conditions and diseases, and also in different settings of care and approaches, from prevention to treatment. To achieve this purpose, the course has met an outstanding group of speakers. I would like to take advantage from this opportunity to express them my deepest gratitude. All of them are among the highest experts in the world in their field of interest. Moreover, all of them have led some of the most contributing studies to show the benefits of physical exercise in this group of population, the older people, the way of implementing the programs, and the target populations among this population, with a preferential focus on those who are frail. Recently, many of them have contributed to the document International Exercise Recommendations in Older Adults, Expert Consensus Guidelines, published at the end of the last year in the Journal of Nutrition, Health and Aging. This document, I think, means a true milestone for all of those working with older people. I am pretty sure that this set of webinars will fill some of the expectations of the attendees and will contribute to strengthen the role of IAGG in helping to the provision of the best care to all the citizens. Thank you very much for your interest in this web series.
Hello, I am Miquel Izquierdo, Professor of Physiotherapy and Exercise Science in the Public University of Navarra and the Navarra Biomed in Pamplona, Spain. First of all, I would like to thank Professor Rodriguez Mañas, Director of the Global Aging Research Network and the International Association of Gerontology, to the opportunity to coordinate this seminar, as well as the geriatrics and the panel of experts and professors who will participate in this online seminar entitled Exercise Recommendations in Older Adults, Update State of the Art. Experts are going to talk about the important role that both structured exercise and overall physical activity play as preventive strategies for many chronic diseases, including cardiovascular disease, stroke, diabetes, osteoporosis, and obesity, improvement of mobility, mental health, and quality of life, as well as reduction in mortality, among other benefits. Notably, exercise intervention programs improve the hallmarks of frailty. For example, low body mass, strength, mobility, physical activity level, and energy, as well as cognition, optimizing functional capacity during aging. They also highlight in the manuscript that the role of the exercise in the prevention of disease and the management of several age-related disease and conditions is increasingly evident, including syndromes for which the benefit of pharmacological treatment is controversial. Despite its multiple benefits, exercise is not fully integrated into geriatric medicine practice. It is still absent from the core training of most geriatricians and other healthcare professionals. Also remark that in an area of complex regenerative medicine, when some scientists are even considering the expansion of human life well beyond its known limits, we must not forget the simple and important messages. Exercise is not just for children and younger adults. People of advanced age can adapt to exercise and deserve to benefit from it. In this regard, we will give you a quick look on the recent international expert consensus guidelines of exercise recommendation in older adults, and finally we will focus on BB-Frail multi-component exercise program. Hope you enjoy it and like it. Thank you very much.
Professor Alan Sinclair is an international expert in diabetes and clinical gerontology and founded the Foundation for Diabetes Research in Older People at Diabetes Frail. He is a former professor of medicine at the University of Bedfordshire and former dean at the Bedfordshire and Hertfordshire Postgraduate Medical School. He has also made some contributions at King's College. He's a recognized WHO expert in frailty and older people, and mainly focused on diabetes. He has provided advice for the UK NICE organization, the British Geriatric Society, Diabetes UK, ABCD, Joint British Diabetes Societies, Care Quality Commissions, and the UK government, Department of Health, on matters related to diabetes in older people. He's currently the chair of the European Diabetes Working Party for Older People, the EDWPOP, and has provided diabetes education for the IAGG. He has produced several international guidelines on diabetes care for older people, including the one from the International Diabetes Federation. The title of his presentation will be Value of Resistance Training as part of a multimodal intervention in pre-frail and frail older people with diabetes, the MID-FRAIL study.
Hello and welcome. My name is Professor Alan Sinclair from the United Kingdom, and it's a great pleasure to be part of a symposium organized by Miquel and Leocadio from Spain, two very close friends of mine and colleagues, and two people in the world of science and aging I respect enormously. Today I'm going to talk to you about the relationship between diabetes, frailty, and aging, and the importance of exercise in reversing some of the functional deficit that we see in older people with diabetes. Diabetes is a global pandemic in many ways in terms of the numbers of people that we are seeing each year with diabetes at all ages. Here in data taken from the work I did with the IDF recently shows that the adult population in the world is due to increase enormously to 1.4 billion by 2045. And the number of people accordingly with diabetes also increase as we go up to 2045 in terms of the projected increase. This is an enormous burden of a significant chronic metabolic disorder on the world's population. When we look at the evidence base for treating older people with diabetes, we see that there are still many shortfalls in this evidence base, and they are summarized in this slide. We can only use extrapolated evidence of benefit for glucose lowering in older people with diabetes. There doesn't appear to be any evidence to suggest the importance or value of glucose lowering in residents of nursing homes. There have been no large-scale intervention studies in older people which focus on functional outcomes in diabetes. And very relevant to today's symposium, there are no longer-term studies available in frail older subjects which have used exercise-based or nutritional-based interventions. Some work we did recently, which was published in Lancet Diabetes and Endocrinology, was work done with colleagues in Europe and in the United States, where we looked at the major shortfalls in the evidence base for diabetes, where research is needed. And at the top of the slide, you see a number of key areas where we know we need to do more research, need to obtain more evidence, and one of which is the second from the top left, comorbidities and complications. This is a vastly important area, and we hope that by using a variety of study approaches, such as randomized controlled trials, observational studies, selecting out subpopulations of patients, we hope that we'll be able to undertake a new approach to diabetes research in older people. And the hope is that the key outcomes in clinical care, which we want to influence, will include improved physical function and cognition. Work that was undertaken quite a number of years ago by my group in Wales was work on diabetes in older people, where we looked at the possibility that diabetes has other effects apart from those that are of a vascular nature, such as the micro and macrovascular complications of diabetes. We showed using a predictive model that diabetes was a major cause of mobility limitation, and that this drew attention to an effect of diabetes on older people with diabetes, which up to that stage had not been researched in any great detail. And even when we accounted for the presence of hypertension, cerebrovascular disease, COPD, cancer, osteoarthrosis, and dementia, diabetes still remains significantly associated with a mobility limitation. Later, there was an impressive systematic review and meta-analysis looking at the relationship between diabetes and mobility and other parameters of physical function in those with diabetes. And quite clearly, there is an excess disability associated with diabetes, not only in the area of mobility disability, but IADL disability and ADL disability. So we ask ourselves, what is driving this diabetes effect on function and mobility? And we expect that the answer will be, well, clearly it must be the complications of diabetes, the effects of neuropathy, the effects on vision, the effects on all the other aspects of the micro and macrovascular complications of diabetes, leading to a state of physical impairment and physical disability. But this was not so. If you look at data from the Italian longitudinal study of aging, which Stefania Maggi led on quite some time ago, you see that when we separately control for the various diabetic comorbidities and look at the excess odds of overall disability, that these together do not account sufficiently for the functional impairment that we do see in older people with diabetes. And in fact, when the analysis was undertaken, classical comorbidities only explain about 38% of such adverse effects of diabetes in women and only 16% in men. So what are other possible causes? One, of course, is the presence of age-related loss of muscle mass, a key feature of sarcopenia, obviously related with changes in power as well, to give it the proper definition. Here in these MRI pictures on the left, you see the femoral cross-sectional scans in a 31-year-old male, at the top 66-year-old male, down below, then a 73-year-old female and an 85-year-old male. And as you can see, that lean muscle mass is decreasing proportionately in those scans. And in the middle here, you see further scans, a 33-year-old male with fairly preserved muscle mass, not so much subcutaneous fat or intermuscular fat. And this individual would have good physical power and strength. Down below, in the middle, you see a 73-year-old male scan. The SPPB is still relatively preserved at 11, gait speed relatively good, but clearly some change in the amount of muscle available for 100% function. And in the scan at the bottom, you see someone who about a decade older, male, the SPPB score has dropped, therefore there's evidence of physical impairment, the gait speed has dropped, and this is classically shown by a decrease in lean muscle mass and an increase in intermuscular fat. So these could be changes that might be accounting for some of the influences in older people with diabetes in terms of their physical function. When you look at some of the elegant work of Park and their group in the US from the Aging and ABC study, again, quite a number of years ago, you see that in comparison with those without diabetes, subjects with diabetes have lost more lean leg mass, and their power has also dropped significantly below that of those without diabetes. So again, we're seeing an accelerated loss of muscle in those with diabetes compared with those who don't have diabetes. And again, this may be another factor. But when we examine all the data, it's still fairly clear that the comorbidities associated with diabetes, the sarcopenic effect, the accelerated loss of muscle effect of diabetes, still together, it's not enough to account for the physical impact of diabetes in older people. And we now feel that the reason is that it is due to frailty, a concept developed by Linda Fried and colleagues 2 decades ago, in which 5 particular features would characterize someone with frailty: weight loss, exhaustion, low gait speed, low grip strength, and low physical activity. These were based on data from the cardiovascular health study that Linda Fried was involved with. So this was one concept of physical frailty. Since then, Ken Rockwood and other colleagues have been developing the cumulative deficit model of frailty, where in a sense, frailty consists of a number of deficits, which lead in an accumulative way to an increase in the likelihood of someone being frail. And in the United Kingdom, we have a software system in all general practices which can calculate an electronic frailty index score. And this score can have a prognostic influence on the likelihood of something bad happening to a particular individual, depending on that score. So here we see that an electronic frailty score greater than 0.36 has a 6-fold increased risk of admission to a care home. So when we think of people with frailty, we think of people who are diagnosed with a physical condition that is likely to lead to an increased risk of a fall, worsening mobility, worsening activities of daily living, disability, likelihood of admission into hospital, and an increased risk of decreased survival. And on the right of this slide, data from Spain, from Leocadio's group, shows that irrespective of the frailty measure used, whether it's the FTS or the frailty index, survival is significantly reduced in those cases of moderate to severe frailty. Nice work by Kalyani and colleagues in the US, data from the Women's Health and Aging study showed that hyperglycemia per se is associated with the likelihood of developing frailty and with lower limb mobility impairment. And in these 4 diagrams, you see that on data, 9-year follow-up data, the relationship between those that had an HbA1c greater than 8% in the old units to be associated with an increase in the risk of frailty, walking difficulty, low walking speed, and low physical performance. Nice studies that have been described well, such as the Whitehall Prospective Study, the Mexican Health and Nutritional Survey in 2016, and the Japanese Community Survey 2016, all show that diabetes, with or without comorbidities such as hypertension or the presence of complications, are all associated with an increased risk of developing frailty. And this is very important. Very elegant and sophisticated work by Leo Rodriguez Mañas, Leo in Spain, and his colleagues, who examined in detail some of the pathophysiological basis for the development of frailty. Their work showed that there was a close relationship between the cycle of inactivity that we do see in many older people, particularly those that are of advanced age or have chronic diseases or even have become obese, that there is a close relationship between this cycle of inactivity and the cycle of frailty, which is shown on the left of the slide. Insulin resistance is a key feature driving some of these changes, leading to an increased risk of developing sarcopenia, and then all the other changes leading to the development of frailty. And this intricate mechanism of developing frailty is well described in their important review. In my view, hasn't been better since. So how do we use this background of work to take a step forward in looking at older people with diabetes and seeing whether we can reverse some of the functional deficits? Splendid work by Miquel's group in northern Spain, based on a systematic review of numerous studies looking at the influence of exercise on the risk of falls, gait ability, and balance in physically frail older people, suggested that it is incredibly important to develop a multi-component exercise strategy based on strength training, endurance, and balance training. And using this type of approach, we may be able to influence the functional impairment trajectory in older people with diabetes. And so Leocadio and myself, with the support of many colleagues across Europe, were able to convince the European Union to fund the Mid-Frail study, a very important study based on the interventions of resistance exercise, nutritional education, and optimizing blood pressure and glycemic control in older people with diabetes, a process we call medical optimization. And this study was widely advertised across Europe, looking for people to recruit, and that process went very well indeed. The main objective was to evaluate the effectiveness of a multimodal intervention in both frail and pre-frail subjects based on the Fried criteria. These were subjects over the age of 70, they had type 2 diabetes, and we also wanted to look at other aspects of them, such as quality of life. There were a number of secondary objects which are described here, secondary objectives described here, such as health economic analyses, carer burden, and changes in quality of life. So an ambitious set of objectives, but primarily based on whether or not this type of multi-component exercise strategy can make a difference to physical performance. And as you can see, the study was undertaken in 7 countries in Europe, and the colleagues were incredibly supportive, incredibly enthusiastic, and they all participated in a number of pre-trial sessions where we looked at how to get the best possible use of the interventions that we were employing, how to coordinate the studies well, and how to recruit optimally. This was an exciting time in the course of research of diabetes in older people, the first largest randomized controlled trial in the world in this area. The inclusion criteria, apart from being able to give written informed consent, was that subjects were to be 70 and over and to have had type 2 diabetes for 2 years. And we used the Freed criteria to diagnose frailty, indicated by these 5 parameters of weight loss, exhaustion, physical activity, slowness, and a weakness. And we said that frailty was diagnosed when there were 3 or more positive criteria, and pre-frailty when there were 1 or 2 positive criteria. Exclusion criteria were people who had had advanced physical impairment based on the SPPB score, or an inability to carry out the SPPB, which, as you know, is a set of 3 different procedures, including gait speed, strength, rising from a chair numerous times, and balance. Other exclusion criteria included those whose mini mental state examination was less than 20 on the score, and a myocardial infarction in the previous 6 months, or the presence of heart failure, grades 3 and 4. And also, we left it to the judgment of individual investigators if, in their opinion, based on their clinical experience, there was another contraindication, or this subject was unlikely to be able to positively participate. Here we have the consult flow diagram of the numbers involved who were assessed for eligibility into the study, those that were randomized, and so on. And overall, we felt this was a highly successful recruitment campaign, and the consult flow diagram testifies to the large number of subjects that we were enrolling into this randomized controlled trial. These were the resistance exercise interventions, seated bench press and leg extension. And we wanted to achieve a percentage MVC of 40 to 80%. And the frequency of this intervention was twice a week. Often it would be a Monday and a Thursday, or a Tuesday and a Friday, or something as that, depending on the site that we look at. These interventions, exercise interventions, were complemented by 7 sessions of nutritional education based on a nutritional educational booklet developed by us as part of the clinical trial. And these were conducted usually during the first couple of months of training. And whilst the exercise itself was delivered twice a week for 16 weeks, these were educational sessions delivered once a week for about 7 weeks. And it worked very well together. And we ensured that dietitians or other qualified personnel were supervising, invigilating these educational sessions. So the study went really well, and we were delighted with the outcomes. And the key outcome that we saw at the end of the study was, at the end of 1 year, we saw a significant improvement in the SPPB score in the intervention group compared with the usual care control group looked after by their general practitioner. And this is shown in this diagram. And we felt that these changes that we saw were clinically relevant and significant. This was published in the journal Cachexia Sarcopenia Muscle, a high impact journal, specialist journal. And we were very pleased with the feedback we received from the data that was shown. The rate of compliance in the study was 82%. The mean improvement in the SBPB score by protocol analysis was 1.04, again, which we feel is clinically meaningful and would be observed in a patient with type 2 diabetes, an older patient, and would have clinical relevance to them in their daily functioning. And more than half of those allocated to the intervention group showed an improvement of at least 1 point in the SBPB. There was a loss to follow-up, about 1 in 5 subjects, mainly those that were frail. This was expected and is comparable to many other studies in this age group. And when we looked at the health economic perspective, we were hoping to show that the use of an intervention in these types of patients would also be economically viable. Of course, we would have to insert into the cost analysis the costs of the intervention apparatus itself. But even when you did that, and then you looked at other costs, in the intervention group, there was a significant fall in the costs associated with hospitalization during that 1 year of the trial. And the overall costs were less, and therefore this proved that this type of multi-component approach based on exercise, nutritional education, and medical optimization is beneficial in terms of the health economic aspects of diabetes in older people. So our summary is that this was a multimodal intervention in older, frail, and pre-frail subjects who had type 2 diabetes, and their functionality, their physical functionality at 1 year of follow-up has improved. The effects of the intervention are shown early after the starting of the program, and it's maintained a long time after finishing. Don't forget, the intervention finished at 16 weeks, and we're looking at data at 1 year. So there is a persistence, a resilience in a sense of that influence in these older people with type 2 diabetes. The patients in general showed a good compliance and adherence to the interventions. They're highly cost effective, and it appeared to be a very safe program indeed. Now, what are the implications? The initial implications are that there is now a greater recognition of early functional improvement by exercise in older adults with diabetes and frailty. And in fact, there is talk of the reversal of frailty. There are likely functional benefits in care home and housebound frail older adults if such a program could be applied, instituted within these settings. And another initial implication is that commissioners of diabetes services should know that the results of this study, and they should consider introducing these type of interventional programs to reduce healthcare expenditure in older adults in frailty, and then at the same time improve their clinical outcomes. So what do we need? Well, we need greater dissemination of these findings into the diabetes and geriatric medicine communities throughout the world. We need to do more pilot studies of exercise programs in care homes, in non-bedbound residents, and in non-bedbound residents. And we need to start looking more closely at community-based assessments, including GP assessments of frailty, to identify those at high risk of hospital admission, and therefore to intervene to prevent that. Thank you very much for listening to me, and I hope that I've been able to show you the benefits of exercise, multi-component strategy exercise in older people with diabetes, the commonest chronic metabolic disease in the world, and one in which there is a significantly high risk of functional impairment. Thank you very much.